Hello, this is Dr. Robert Miller from ASCO's Cancer Link. Thank you to the organizers for asking me to participate in this panel to discuss the role of real-world data in post-marketing strategies to benefit older adults. I have no commercial interest to disclose. So first, some definitions. What is real-world data and real-world evidence? It's interesting that these things are often defined in the negative, in the sense that real-world data is what's not part of a clinical trial. The FDA did publish some definitions in their real-world evidence framework that came out in 2018, and they refer to real-world data as that which is routinely collected during the delivery of healthcare from a variety of sources, such as electronic health records. And real-world evidence, of course, is the evidence that arises from the use of real-world data, specifically in this context to understand the benefits or risks of a drug or a device. But I think it's important to recognize that there probably is a more nuanced definition and a spectrum of real-world data. If you sort of consider this as flowing from left to right, the randomized clinical trial is obviously the most controlled and extends all the way over here to data that's captured in routine clinical practice. Again, as we consider electronic health record data, claims databases, and so forth. But in between, there are probably other data sources such as pragmatic clinical trials, patient surveys, cancer registries, and so forth that fall somewhere in the middle. So it's important to kind of keep these definitions in mind as you consider the full spectrum of real-world data and how it can be used to benefit older adults. Now, real-world data has gotten a lot of attention lately as potentially complementary to randomized clinical trials, and the advantages, which I won't go through in detail, are potential advantages are well known in that real-world data may reflect the reality of the effectiveness of an agent of what happens in the real world. But focusing a bit on some of the disadvantages and challenges of real-world data, I think largely this is around data quality issues, specifically data missingness. And data can be missing from real-world data sets both at random and not at random. It's important to try to distinguish those two. Moreover, data elements are rarely standardized, and that also impacts the data quality. And of course, in the real-world data setting, it's not possible to have blinding or control groups. The result is that real-world data sets are subject to various biases, some of which I've described here, I name here, and this can impact the ability to use outcomes. Now, considering specifically the use of electronic health record data in studying the older adult population, you have to understand that you're going to be limited to what is available in the current source electronic health record system. So in the example of the Geriatric Assessment, we know that unfortunately it's not always being performed, but even when it is performed, the results are often not captured in structured data. If you look at the components of the geriatric assessment, some of these things here, again, many of these elements are sparsely populated in real-world data fields in these databases. Things like functional status beyond the ECOG performance status, often not there. Documentation of falls, cognitive function. Comorbidities is interesting. We looked at this at Cancer Link, and comorbidities as ICD-9 or 10 codes can come from the problem list in the electronic health record, but there often is a missingness issue. So if the EHR is from the practice or the site where the oncologist is not treating patients for comorbidities such as hypertension or diabetes, these problems may not appear in the problem list. So you may not see these listed as comorbidities. And obviously, there are a lot of gaps to more challenging things to document, like the patient's psychological state and the social support of the patient. Most importantly, the outcomes that are of importance to older adults, such as the impact of treatment on patient functioning or cognition, oftentimes can only be obtained through manual data abstraction or curation, or through the use of patient-reported outcome tools. So to say a few words about ASCO's Cancer Link as an example of a real-world data source, Cancer Link is a health technology platform that was developed and implemented by ASCO. CancerLink is a wholly owned nonprofit subsidiary of ASCO. The platform collects and aggregates real-world cancer data, largely from electronic health records, but also some other data sources like cancer registries, and serves two purposes. Most importantly, CancerLink is a quality improvement tool. It delivers dashboards and quality measures, reports back to physicians to improve the quality of care. But it's also a database, and what we call CancerLink Discovery is used as a source of real-world data to advance discovery. And CancerLink at present is the only physician-led big data platform in cancer. This slide shows some of the characteristics of the CancerLink database. As of now, CancerLink has over 4.2 million patients captured in the database. 2.1 million or so have a primary diagnosis of malignancy. And as you might expect, this is the range of diagnoses by anatomic site that we see, representative of what's commonly encountered in clinical practice. Pointing out the range of ages, again, representing population averages in oncology practices, the median age in CancerLink is around 67. And so there is a representation, unlike many clinical trials, of many older patients in their 80s and beyond. The spike here for patients greater than 90 is that we aggregated data for anonymity for patients older than 90 or younger than 18. And more importantly, CancerLink represents longitudinal clinical data. So it's richly representative of things like lab tests and drug orders, encounters, and so forth. And so it can be used as a source of data for looking at real-world outcomes in this patient population. So just a quick case study using the CancerLink data. We look to replicate, if you will, some of the aspects of the Paramount trial, which was published a few years ago in the JCO. Paramount was a clinical trial that looked at stage 3B and 4 non-squamous, non-small cell lung cancer patients, specifically addressing the question of continuation maintenance therapy with pemetrexed. So in this study, 939 patients were entered in the study. About 700 had either a response or stable disease post 4 cycles of induction therapy, and 539 patients were randomized to maintenance pemetrexed or placebo. And as many of you recall, this was a positive study. It showed that the median overall survival in the treatment group that got the maintenance pemetrexed was 13.9 months, which was statistically significantly better than the 11 months in the placebo group. So we looked at a similar patient population in the CancerLink database. We liberalized the criteria for entry a bit, didn't just look at the combination of cisplatin and pemetrexed as induction, but rather any platinum doublet for 2 to 8 cycles, and then looked at the patients that got at least 1 cycle of maintenance pemetrexed, with or without other therapies. And as you can see, this column here in the table shows the Paramount results for comparison, and this is what we saw in CancerLink. Obviously, a lot more patients and a lot longer follow-up in CancerLink. But interestingly, the older patient population, greater than 65, was more richly represented in the CancerLink database compared to Paramount. And based on race, the CancerLink data, not surprisingly, were much more diverse, much more representative of the population. Paramount was done mostly in European centers, so not surprisingly, this was a distribution. And the other thing of note is that we saw that a significant minority of patients had additional therapy as maintenance, in addition to the pemetrexed given concurrently. So that could be typically pembrolizumab or another immunotherapy agent. And these are the results. These are the survival curves over here on the right from the CancerLink analysis, looking at patients in the blue, less than 70 years of age, and in the orange, 70 or more years of age. And you can see that the median survival is similar, and it also is similar to what was seen in the Paramount study. So that I think the findings from this show that first, as a proof of principle, you can go into a real-world database like CancerLink and replicate these studies and see what really happens in a more diverse and potentially older population. And I think more reassuringly, for the specific agent, you can see that there was a similar overall survival in this population beyond what was seen in the clinical trial. And finally, what are some of the strategies that we can think about to benefit these patients in terms of how best to use real-world data? I think most importantly, working to improve data quality is essential. And that's certainly the biggest challenge. That may involve improving the adoption of existing data standards like M-code, minimal common oncology data elements, documenting social determinants and components of the geriatric assessment, as I said, largely missing, and clearly the impact of patient-reported outcomes in a more standardized way of documenting toxicity to note adverse events. But I think you can also see that using existing data sources like EHR data and CancerLink or registry data is currently suited to measure certain things like the metrics of disease burden in the population, whether whether physicians are adhering to guidelines in this patient population, timeliness of care, as well as patterns of care looking at the utilization of new agents. Thank you very much.